You could just unmute Carolina.
There we go. Welcome, everybody, to our Miami Global Brain Tumor Symposium on Wednesday, October 28th at 5 p.m. Let's see. I'm Carolina Benjamin. I'm Assistant Professor of Skull Base and Neuro-Oncology at the University of Miami, as well as Director of our Canes Dissection Lab. I'm joined today by Dr. Ivan, who is the director of this fantastic symposium and who's here with us on audio, as well as our co-directors, Dr. Jacques Morcos, professor and co-chair, as well as director of cerebrovascular and skull-based program, and Dr. Ricardo Comatar, who's professor and program director, as well as director of our brain tumor initiative. We'd like to give a special thanks to the people who make the symposium possible: Christina, Roberto, Damari, Ingrid, and Ignacio. Special thanks for helping us out every week. And this is you can find us on social media here. We have access on Twitter. We are live on YouTube, so you can join us there as well. All these symposiums are actually recorded and will be available through our website. And you can either register using Dr. Ivan's or the University of Miami Neurosurgery's account. In line with these, every Thursday, Dr. Morcos, as well as the rest of us, have been also hosting a cerebrovascular and skull-based symposium at 5 p.m. They are also fantastic, and tomorrow's sessions will be really good on wide-necked cerebral aneurysm. So please join us if you're available. Here's the link down here if you want to register for that. And just a sneak peek for next week, we will be talking about glioma connectomics, rethinking what eloquence means and what to do about it with Dr. Michael Shagru. So I think that will be a fantastic session. If you guys are interested, please join us again next week, 5 p.m. So some housekeeping rules: participants, if you can ask your questions by using the Q&A button on the bottom, we will get to as many questions as we can. We are not offering CME, but you'll get an email confirmation of your participation. And please follow us if you think these are interesting, and share them with your friends who you think that might like them as well on Instagram, Twitter, and YouTube. Now to the interesting part: this week's panelists: Dr. Khalil Abdullah from the Department of Neurosurgery, brain tumor specialist at the UT Southwestern Medical Center; Dr. Roberto Jose Diaz from McGill University in the Department of Neurosurgical Oncology there, as well as Brad Zachariah, welcome back, director of the Brain Tumor and Skull-Based Program at Penn State. And then now for our special speaker, Dr. Geleray-Zadeh, welcome. I'm glad you joined us. We were waiting for you, so it's perfect. It's my very, very honor to introduce you, fellow female and somebody I look up to very much. Dr. Geleray is a world-renowned brain tumor surgeon and scientist. She's also the first woman chair of the Division of Neurosurgery at the University of Toronto, which is a fantastic feat. Congratulations again. She's a professor there, neurosurgeon scientist, and co-director of the Krembil Brain Institute at UHN and the Wilkins Family Chair in Brain Tumor Research. She's also the co-director of the Elizabeth Robb Neurofibromatosis Program, Her clinical practice focuses on the skull-based neuro-oncology with dedicated general brain tumor clinic and many multidisciplinary tumors clinics that she's established. She's very actively involved with, including skull-based, pituitary, brain mets, gamma knife, NF. She is actively involved with and is dedicated to the goal of advancing surgical clinical trials. And in parallel, she has an active research laboratory focusing on integrated multi-platform molecular analysis of brain tumors, together with a focus on understanding the molecular response to targeted therapies such as anti-angiogenesis and metabolic inhibitors. Her laboratory is funded through peer-reviewed grants from a number of agencies such as CIHR, Terry Fox New Investigator Grants, CCSRI, CRS, Brainchild, as well as others. She's very active in many local, national, and international committees in the field of neuro-oncology. And she's also the current president of the Society of Neuro-Oncology, as well as editor-in-chief of the Neuro-Oncology Advances. We thank you so much, Dr. Zadeh, for taking the time out of your very busy schedule to share your thoughts with us on brain tumor methylation and how it impacts the field of neuro-oncology. If you could please share your screen with us today, and we'll get started.
Can you see my screen?
Yep,
yes, we can see your screen. We can hear it clearly. You can start.
Great. Carolina, Dr. Benjamin, thank you so much for the introduction. I wish this was in person. I enjoy Miami. I love the ocean, the beach, and it just feels so peaceful once you step out of a plane from cold Toronto to warm Miami. So hopefully in the future, we are able to go back to traveling to some extent. And I just want to congratulate yourself and your entire department really for putting on such amazing lectures. The University of Miami series, I think, has very quickly, since COVID started, become very popular and well recognized with a lot of excellent content and outstanding speakers. So I wanted to speak to you today about how perhaps we can integrate methylation signatures to change the paradigm of how we manage brain tumors. I have no conflicts or disclosures. You're all well familiar with the range of brain tumors that we manage. The pituitary macroadenomas are typically those that we treat with surgery. Endoscopic resection of this tumor will restore vision. And generally, we continue to follow these patients 95% of the time through surveillance postoperatively with no additional intervention required. Acoustic schwannomas over the last 10 to 20 decades have changed considerably in how we manage these patients, with the advent of gamma knife becoming really well established as a treatment modality, operating on those that are greater than 3 centimeters and treating them with gamma knife radiosurgery predominantly. And then meningiomas are the tumors that are increasing in incidence as the aging population increases, and they tend to evade us in some of the categories of meningiomas that we deal with. But most prominently, the majority of our research does focus on gliomas, as they continue to have one of the worst prognosis associated with any cancer in adult population. And in large part, as you know, by the time that the patient presents with a mass that's recognizable on the MRI, already there is significant invasion of the cells, as you can see on this histology cross-section of multiple areas of invasion. And though we increase the armamentarium of improving extent of resection, the outcome of the patients are continuing to be poor. So I was hoping today that I would show to you some of the work that we've done in the lab to see whether I can convincingly demonstrate that some of the results can in fact shift the paradigm for management of these patients. When you look at the paradigms that we currently have, they're relatively standard and straightforward. A patient gets diagnosed because of a symptom or a finding that they've had on clinical exam, and a tumor is diagnosed on MR. Sometimes they go on to have surveillance imaging. And at the point where surveillance imaging shows a change that concerns the clinician on image features, or the patient's symptoms change, we then recommend surgical resection. From the time of surgical resection, a minimum of a week is required for the pathologist to be able to give us a diagnosis associated with grade and some of the molecular signatures. And from there, we then go on to recommending chemoradiation if the patient requires it. And chemoradiation are relatively standard and limited options for multiple different types of brain tumors. And if it fails, we go on to clinical trials, which unfortunately at this point remain not terribly successful. So can we in fact shift the paradigm and make this more sophisticated as we learn more about the biology of the tumors? And the three areas I'd like to focus on is to show you how in fact methylation can improve the molecular diagnostic of the brain tumor. We can use the methylation signature as DNA biomarkers to perhaps avoid surgery. And we can use the methylation signatures to be able to accurately predict risk of recurrence, and as a consequence, be able to more individualized, in an individualized manner, recommend treatment for the patients. If we look at the WHO fascicle, there's over 150 distinct brain tumor types. Of course, majority of them are not what we deal with on a daily basis. And majority of these diagnoses rely solely on histopathology. Since the 2016 fascicle, there is now more integrated molecular histology that comes into play. And so if you look at the last 10 to 20 years, you could see that we've evolved in our understanding of the histology of brain tumors being divided as an astrocytoma, astrocytoma, oligodendroglioma, to in fact dividing them between whether they have an IDH mutation or an IDH wild type, whether they're 1p19q co-deleted or intact, and whether they have p53 mutation and so forth. And the molecular signature governs the outcome of the patients and prognosis, and so bears on counseling of the patients, and to some extent bears on our decision-making as to what we would do next in our paradigms that I've shown you. A seminal paper in 2018 was published by the DKFZ group in Heidelberg, where they looked at over 82 different brain tumor types with methylation and identified that in fact the methylation signature of the 82 different brain tumor types, ranging from glioma wild type to glioma IDH mutant, etc., are vastly different and distinct. And so the signature of the methylation of these tumors can in fact help and aid as an adjunct in improving and refining the diagnosis of brain tumors that we deal with. So at this stage, I think that we can in fact look at how we can introduce methylation to shift the paradigm. And I'd like to show you some of our institutional results where we can integrate the diagnosis on histopathology with methylation to improve diagnosis. We were one of the early adopters of using methylation at University of Toronto. I have to give credit to my colleague at the time, Ken Aldape, who was our neuropathologist, and since he has moved on to NCI. But he brought with him, when he moved to Toronto, the methylation technique, and we've continued to use this in our clinical practice. We reviewed our experience between November of 2015 to September of 2018 at our site at University Health Network, where we did approximately 1,700 cases over the 3 years. And we looked to see which one of these was actually falling within a diagnostically challenging case, defined as a case where two expert neuropathologists could not reach consensus for the diagnosis. There was a discrepancy between the histopathology diagnosis and what us as clinicians felt that the tumor pathology should be. In other words, there were features clinically that did not correlate with what was thought to be histopathologically the diagnosis. And we required molecular subtyping of that tumor. Of the 1,700 cases, 55 were challenging cases that had methylation on them. The diagnostic workflow included methylation-based classification, sometimes needing incorporation of copy number alteration, histology being reevaluated after methylation was done to reach an integrated diagnosis. And the results are summarized as the diagnostic change happened in 24% of the cases. resolution of a differential diagnosis, where the two neuropathologists could not reach consensus, happened in 31%. Upgrade of the WHO classification was 18% and a downgrade in 5%. Cases where an assignment of a grade was not possible by histopathology, methylation was able to do so in 4%. And this is the plot where it shows the initial pathological diagnosis based on histopathology and WHO grading. And this is the final diagnosis based on integration of methylation together with histopathology. And you could see that there is a considerable crossover, as I showed you. We then look to see if the refinement of the diagnosis based on methylation, in fact, had an impact on clinical outcome. And I would say this is probably the first and more extensive results that I've showed that we have in literature that we published. And this is one case that I highlight to you, a young lady who was diagnosed with a high-grade frontal tumor presented following a seizure. 3 neuropathologists, expert neuropathologists, were unable to actually decide on the actual diagnosis. 1 external neuropathologist reviewed the case as well, and the tumor was diagnosed as glioma, not otherwise specified, high-grade IDH negative. Following discussion at tumor board, the patient was felt to have best go on to chemotherapy temozolomide and fractionated radiation. It happened that at the time of this diagnosis, the patient's father actually sought us out, and we had sent out the tumor for methylation. The results on methylation by classification came back as a DNET, which, as you know, the best course of action following this diagnosis is observation. And now, approximately 5 years later, we have avoided chemoradiation and the patient remains stable. And I got a very heartwarming email from her. She just entered medical school. The other examples similarly show that based on the change in diagnosis, the initial recommended treatment plan changed to a new treatment plan. And so when you look at all of our results together, 84% of the diagnostic challenging cases received a meaningful clinical diagnostic alteration. Of those, 24% had a change in the diagnostic entity, 31% resolved in their differential diagnosis, and 27% changed in the grade of the tumor, which bears on clinical decision-making. Overall, of the cases, if you look whether there was a significant change in clinical management, avoiding chemoradiation or changing the recommended regimen, 15% of the cases had a change in clinical decision-making, which is a significant number when you think about the alteration that happens with integration of methylation. And so hopefully, based on the work that I've shown you, and these are published in Clinical Epigenetics, the first author is Jeff Zuccato, a neurosurgery resident in my lab, and Shireen Karimi, who's a neuropathologist. And hopefully, based on what I've shown you, you're convinced that in fact methylation does help distinguish some of the difficult and challenging cases and help refine the diagnosis to aid in decision-making and management of brain tumor population. So with that, I just want to show you a few pictures of our neurosurgery resident body. We have 37 residents, a group of very young, energetic, intelligent individuals who I'm hoping to show you more of their pictures as I go through the talk today. And so this is an example of some of them pre-COVID, as you see, no masks on, enjoying social outings. The next area I wanted to talk to you about is the value of using circulating tumor DNA and the methylation signature that we can detect in the circulating tumor DNA. This histology is familiar to most of you. It's a typical appearance for a glioblastoma section where there is necrosis and pseudopalisading proliferative cells with hyperproliferative endothelial cells piling on top, forming glomeruloid bodies, giving us the typical diagnosis of a glioblastoma. This is a section of what would appear to us as perhaps a normal brain, and courtesy of Professor von Deimling from Heidelberg, I'd like to draw your attention to the circles. If you do an IDH mutation stain on this section, which appears relatively normal, you could see that there is IDH mutation, and so early signs of a low-grade glioma developing in this brain section. The reason I mention it is to again highlight that in the last 10 to 20 years, our understanding of how we diagnose brain tumors, in particular glial tumors, has changed based on the IDH status and the 1p19q. And this bears on the prognosis of the patient, where a glioblastoma IDH wild type has the worst prognosis, and a low-grade glioma with IDH mutation 1p19q co-deletion has a significantly better outcome. And so these two groups are vastly different in their prognosis, again, in how we counsel the patient, but more importantly, how as surgeons we decide to intervene is very much dependent on where on the curve individual patients would fall. So if we have this young man who presents to the emergency department with a focal seizure, you can see on the MRI, there is no enhancement, but there is this lesion. If we look at the treatment paradigms from the MR diagnosis, I think some of us will suggest surveillance imaging and continued repeat MR imaging until there are changes on the MR that are concerning, in which case we would recommend surgery. Others would recommend surgery upfront with the belief that early maximal safe resection is important. And then once we have the molecular diagnostics back from our pathologist, potentially adding the methylation that I showed you, the patient may benefit from chemoradiation. So at this point, I think I can show you that circulating tumor DNA can add a layer of sophistication in our paradigm to be able to make a decision together with the MR diagnosis and what we identify on liquid biopsy, to be able to then more accurately and more confidently recommend surveillance versus suggest surgical intervention. So tumor cells, we know, shed circulating pieces of DNA into our bloodstream, and this can be captured. Majority of the capture of the circulating DNA has focused on looking at mutational pattern, which becomes challenging because the repetition of a mutation is not sufficient on all of the different circulating tumor DNAs to be able to actually capture that with accuracy. But if you look at methylation on the pieces of DNA in the blood, because the signature is preserved, most likely it would increase the likelihood of being able to detect the circulating DNA that has the methylation signature from the tumor distinct from our normal methylation signature. And so this is where a needle in the haystack can identify using methylation signatures of the circulating tumor DNA, whether we're dealing with a brain tumor with a particular grade or a particular histopathological type and a mutational signature. My colleague Daniel de Carvalho, a scientist at Princess Margaret, published this paper approximately a year ago in Nature, where they looked at circulating tumor DNA through a pull-down mechanism and looked at the methylation signature of cancer. So in this example, early pancreatic cancer in the tumor, comparing to the plasma, comparing to the matched normal plasma. And you could see that the methylation signature is very different in the plasma of the pancreatic patient compared to normal healthy matched counterparts. And the methylation signature of the circulating DNA is matching that of the tumor itself. They were then able to show that you can identify tumors with a high accuracy based on the methylation of the circulating tumor DNA in AML, where the accuracy is 100%, given that it's a liquid hematological malignancy, and so it is in the blood. Breast cancer, lung cancer, pancreatic cancer, renal cell, etc. We then wanted to see whether this same technique, what we refer to as CF-MEDIP, the pull down of the circulating free tumor DNA and methylation, can in fact detect intracranial tumors and be able to use this as a diagnostic approach. This is the CF-MEDIP, the circulating cell-free DNA that's precipitated and subsequently through bisulfite conversion and sequencing, looking at the methylation signature. We looked at a total of approximately 500 samples, and we detected 59 gliomas compared to other tumor types within this. And you could see that the area under the curve, the extent of the accuracy of the test detecting gliomas versus all other classes is extremely high. And so with high accuracy, you can in fact detect and distinguish the methylation signature from other cancers in the blood. Similarly, if you look at gliomas versus other and look at IDH mutant gliomas versus IDH wild type, it's very clearly distinguishable. And if you look at grade 2 or 3 gliomas versus grade 4. This is again another way of demonstrating the data where you could see that the black dots being our gliomas and glioblastomas compared to other tumors, the differentially methylated regions are distinctly different. And this is a heat map essentially showing the same data. We then looked to see whether there was a correlation between the methylation signature in the plasma and that of the tumor, and you could see that there's a very nice correlation. And again, the accuracy of this is quite high as a test. And similarly, if we repeat this in patient population, the correlation of the methylation of the tumor and circulation in the circulating DNA in the plasma is very similar. You could see that if you compare gliomas to other cancer types, there's a very distinct signature associated with gliomas. And if we use this very same one based on cell lines and superimpose it on what we have of the tumor patient population, again, gliomas is very distinctly distinguished from other tumor types. We also wanted to see what happens with the range of intracranial tumors. So not just gliomas, but include meningiomas, hemangioparasitomas, other low-grade gliomas, and other low-grade tumors, such as neuroectodermal tumors, and to look at the distinction between IDH wild type and mutant. In meningiomas, you could see that based on the circulating tumor DNA, again, with a relatively high accuracy of 0.9, we are able to distinguish meningiomas from other tumors. What's really quite fascinating is that for hemangioparasitomas, almost with the 100% accuracy, you can distinguish hemangioparasitoma from other tumors. My postulate is that hemangioparasitomas come from the parasites. The shedding of the content into the blood is very high, and so the signature is very distinct. On a practical note, I think this test does help us as skull-based surgeons and brain tumor surgeons in general, before going into surgery, to distinguish for those rare cases where a meningioma in fact ends up being a hemangioparasitoma, so we can plan better with regards to blood loss that we would anticipate during surgery and some preparations otherwise preoperatively. If you look at the IDH mutant gliomas versus others, the accuracy is in the neighborhood of 0.82 compared to other glioneuronal tumors, because we thought, well, maybe not all, the signature that we're picking up doesn't distinguish between other lower grade glial tumors, but in fact, you could see that that's not the case and it distinguishes it. One observation and finding that was interesting is that the IDH wild type gliomas, however, are not as accurately distinguishable. And if you look at this population, which are the black dots, some of the color may not show through, the wild type IDH mutant gliomas, though majority of them group together, there's a few of them that group very distinctly. So suggesting that, as we know glioblastoma to be heterogeneous, most likely the circulating tumor DNA also is very heterogeneous, and that heterogeneity shows up in what we pick up in the blood, and perhaps building the hypothesis that we're working on, that you can look at a separate methylation-based classifier on tumor DNA that you see in the circulation, distinct from the tumor tissue itself. So this work was done by Farshad Nassiri, who's a neurosurgery resident that was in my lab, and the postdoctoral fellow, Ankur Chakravarti, who are both first co-authors on the Nature Medicine publication. Daniel DiCarvello is my colleague and senior scientist who really demonstrate the value of being able to collaborate on a project like this. This is a collage of selfies of all of our neurosurgery residents. Again, a large group of young, intelligent, energetic, and extremely fun crowd to hang out with. So this is them in a snapshot. So I hope that I've shown you that with introducing liquid biopsy, we can perhaps refine and add sophistication to the paradigm for treating a patient who presents with an MR finding such as this. In that if your liquid biopsy, with the accuracies that I've shown you, prove that this is a glial tumor, IDH mutant, you may with more comfort feel that you can continue observation and surveillance MRI. Whereas if this tumor had a higher grade and was IDH wild type, you may be more inclined to recommend that the patient go through surgical resection and possibly chemoradiation. We could also look at using the circulating tumor DNA methylation as a means to longitudinally follow patients. And if there's a change in the pattern of the liquid biopsy, the circulating tumor DNA methylation, whether it's the volume that we see in the bloodstream or the methylation signature, potentially use that as an earlier sign of evolution of the tumor outside of what we see on MRI, because often the changes we see on MRI are in fact too far gone and too far progressed for the tumor. So the last part of my talk, I want to show you how we can use the methylation signatures from the tumors that I showed earlier to in fact predict outcome for our patients. Meningiomas are a tumor that you're well familiar with. They can present in various anatomical locations with various degrees of aggressive behavior, alteration in the neurovascular structures, And if you look at the percentage of tumors, of all brain tumors, in fact, they can constitute a considerable portion of all brain tumors. If you remove glioblastoma and other malignancies, meningiomas, in fact, are the majority of tumors that we deal with. If you look at the incidence of disease for meningiomas, you could see that at age 65, the incidence increases compared to the other brain tumor types. And if we look at the map of the world, where it demonstrates the population that are over age 60, you could see that a significant portion of the world are over 60 or nearing that. And so very shortly, if not already, meningiomas are a tumor that we deal with on a common daily basis, and the numbers are increasing, and the age of the population is increasing as well. And so in particular, deciding whether after resection patients benefit from radiation or not continues to be a challenge, in addition to the grade 2 meningiomas that still remain controversial, and grade 3s, whether all of them require radiation post-resection. If we look at histopathology and grading of meningiomas, the distinction between grade 2 and grade 3 tends to be somewhat subjective. And so whether the pathologist can reliably distinguish grade of grade 2 to grade 3 is very much inter-observer dependent. If you look at the histopathology of meningiomas, there's 18 different subtypes, very beautiful pictures on histopathology, but really majority of them don't bear on how aggressive these tumors behave. So our ability to utilize WHO grading is limited. It's certainly important, but it's limited. Simpson grading is what we use as surgeons to say whether we've had gross total resection for grades 1 through 3, or subtotal resection for partial resection or biopsy of grade 3, 4, and 5. And this has stood the test of time. And if we have a good resection, the likelihood of recurrence is low. However, again, it has its limitations. And in fact, if you look at your own institutional experience and your own clinical experience, not all grade 1s have a recurrence risk of 0. And in fact, there's a considerable portion of grade 1 meningiomas that have a relatively high recurrence rate. Similarly, grade 2s, there's a wide range of recurrence for grade 2 meningiomas. And grade 3s, not all of them have a recurrence rate. In fact, some grade 3s don't recur. And we all have them in our practice where the pathology comes back as grade 3, but you've had a good resection and you've continued to monitor somebody for years and they don't have any recurrence. So is there something beyond histopathology that we can use to better understand how aggressive the tumors behave, and more importantly, identify targets of therapy? There have been a few large-scale studies published in Nature where they looked at the mutational signature of meningiomas. And interestingly, if you look at it, as the tumor grade progresses with meningiomas, the mutational burden does not increase. And in fact, you could see that mutations do not define grade 2s and grade 3s beyond NF2 mutations. So really limiting our capacity for identifying the target. There are ongoing clinical trials in grade 1 meningiomas targeting some of the mutations. Whether or not they'll be effective has yet to be demonstrated. If you look at loss of copy number alterations in meningiomas, with grade they do increase. The clinical utility of this perhaps is somewhat limited, though potentially can be used in clinical practice. There are other features such as TERT promoter mutation that with increase in grade increases and possibly can be used as a prognostic indicator. Going back to methylation, in a normal cell, the promoter regulates the transcription and activation of the genes in front of it. In the cancer cell or tumor cell, the promoter is methylated and prevents activation of genes that are sitting in front of it. And so you lose potential tumor suppressor genes and possibly increase proliferation, decrease cell death, etc., contributing to the malignant and oncological growth of a tumor. We thought that perhaps if we look at methylation signature, it can add to histopathology and be able to distinguish subtypes of meningiomas that can help direct our decision-making with regards to treatments following resection of a meningioma. There was a training test set that was done. Meningiomas were taken and methylation analysis was conducted. The test data set was from MD Anderson. This is the paper published by, again, my colleague Ken Aldape and myself in collaboration. And we saw that there were two distinct methylation signatures of the meningiomas. The same finding was validated in a validation cohort from a University of Toronto-based population. And again, two distinct subtypes were identified. Those with a favorable methylation signature and those with an unfavorable methylation signature. And this is distinct of the histopathological grade. As you could see, the histopathology grade 1, 2, and 3 is smattered throughout without binding itself to methylation. At the same time that we were doing this study, the German group, Heidelberg, that I mentioned, also looked at methylation signatures of their meningiomas, and they identified, in fact, 6 groups. And each of these groups have different mutational profiles, different copy number alterations that I've shown you, and more importantly, each of the 6 groups have very distinct outcomes, once again, independent of grade. So with this information, we thought, can we use the methylation signatures to leverage a predictor or a nomogram, a calculator that could decide and determine the outcome of a patient with meningioma? And so individualize it, because on the curves, the Kaplan-Meier curves, my individual tumor, it's difficult to know where on this curve the behavior of the biology of that tumor falls. So we looked at approximately 230 tumors that were from our center in Heidelberg. DNA methylation was conducted. And based on feature selection, we were able to identify approximately 10,000 probes that were annotated and identify 3,237 that were useful for us to be able to create and build the methylome signature. Through a number of computational steps, we were then able to identify a methylome-based predictor and validated it through 2 rounds of additional tumors from, again, our own institution and MD Anderson. And on top of the methylome-based predictor that was validated and revalidated, and in fact, for publication, we did a 3rd validation, we layered the grading of the tumor, the age of the patient, the extent of resection, and other demographics. And there were really a few that came up as significant on multivariate analysis. And we were able to generate a calculator. And I'll show you the calculator in a second. These are the results. These are outcomes based on grade. Grade 1, 2, and 3, very typical for what we understand. Low recurrence rate in grade 1, high recurrence rate in grade 3s, intermediate for grade 2s. If you look at the methylation signature and predict based on that, again, independent of grade, it too separates it out into 3 groups: good outcome, intermediate, and poor. We then thought, is it overriding WHO grade? And can it actually distinguish poor outcome population within different groups? And in WHO grade 1, you could see that majority of the tumors do well, and while their outcome is good, there is a subset of tumors, and again, we see this in our clinical practice, where the outcome is poor. In grade 2 tumors, it's interesting because it really splits the tumors into 3 distinct categories. A group of grade 2 tumors that do very well, and you would argue that this is the group that would not require post-resection radiation. A group of grade 2s, however, that do extremely poorly, suggesting perhaps this is the population that would either benefit more from radiation early upfront or possibly considering a re-resection, and the intermediate category that I would argue remain controversial. Interestingly, equally, grade 3 meningiomas, though majority do poorly, there is a subset that very nicely come out that show that in fact their prognosis is good. And again, this is the population that we all have in our practices of grade 3 meningiomas that don't do poorly. And you could argue that this population, in fact, does not need radiation, and you could avoid giving patients the radiation that's not necessary. So this is how the calculator works. It's weighted from 0 to 100 points. Grade gets approximately half of the points, and in an example such as this, grade 2 tumor gets a score of approximately 25. Extent of resection gets you an additional score, and it's weighted to approximately 20%. And if you had a Simpson grade 3, it gives you a score of 10. The methylome has a weight of 100%. The ruler is based on the methylome score. And a particular hypothetical tumor has a methylome signature of 0.6. You add these points, it comes to approximately 90. This gives you a 0.4 score, a 5-year recurrence score of 0.4, which means that in 5 years, there is a 60% chance that this tumor recurs. And this gives you a sense about the aggressiveness of the tumor, in some extent independent of the WHO grade, and it can refine how we then decide whether the patient goes on to radiation or not. And I would argue as the next step would be, are there targets of therapy that we can identify in this population? And so hopefully I've shown you that at this point, introducing methylation has refined the paradigm at the stage of postoperative diagnosis, in that we can integrate this into our decision-making in our tumor boards for grade 2 meningiomas and in grade 3 in order to decide whether they benefit from radiation or not. And currently at our site, we're at a stage where this information is integrated into our day-to-day clinical practice when the patients are discussed on the weekly multidisciplinary tumor board, and decision is made to do methylation on cases that are controversial, in particular for meningiomas grade 2 and grade 3, or a grade 1 where the surgeon believes that the tumor was more aggressive, and then integrate our methylation results into the Nomogram and be able to use that as a factor in decision-making with regards to radiation treatment or continued surveillance. So I want to show you a couple of examples of this. Both are outside cases that were sent to us for review and methylation analysis. Meningioma that was resected outside, a very good resection, and the pathology came back as grade 2. On the Nomogram, it's available as a web-based tool. You put in the grade of the tumor as grade 2, extent of resection, Simpson grade 4, and the methylation score comes back as 0.896. The 5-year predictive outcome for this patient, recurrence-free survival, is 0.0985. The actual number is the inverse of this. So the likelihood of recurrence is quite high. And you could see in this case, without radiation, 33 months later, the tumor has recurred. This tumor, comparable to the one I showed you last, the histopathology is grade 2. The extent of resection, similar to the last case, is a good resection. The methylome score, however, for this patient is lower. It's 0.9834. The 5-year predictive recurrent-free survival is 0.773, which is again the inverse of this. And 72 months out, in fact, this is now almost 84 months out, the recurrence rate is still remaining low, and there is no recurrence of this tumor. So hopefully the 2 illustrative cases demonstrate the value of using the nomogram. And in fact, in addition to integrating it into our tumor boards currently, we are using a prospective series to be able to, in real time, prospectively validate. So a work like this is made possible by combining and collaborating with multiple sites across the world. And we have a Meningioma consortium with currently 32 different sites that contribute to the consortium. It's either through contribution of tumor material, genomic information, or in collaboration, we prepare scientific articles where we have a special edition, for example, in neuro-oncology that was published in 2019 from a range of genomics, basic science research to clinical factors that impact our decision-making for patients with meningiomas. I want to close in thanking the various funding agencies that fund my lab, the students in the lab. The work that I showed you on meningiomas is predominantly driven by Farshad Nassiri and Dr. Yasin Mamedjan, who is the bioinformatics behind the lab. But in general, I'd like to thank all of my lab members, and I'll show you a picture of them in a second. But I also want to say that I am, as Carolina opened, proud to be the incoming DAN chair. We have 32 faculty across 4 different sites, and it is really my privilege to be in this position for the next few years. In closing, these are my 2 daughters, and these are all of my lab members. Majority of them have contributed to the work that I showed you here. And again, I want to thank all of you for inviting me to be part of these series, and I'm happy to take any questions. Thank you.
That was truly, truly fantastic. Thank you so much. I think a perfect example of how our work in the lab can translate to clinical decision-making and surgical decision-making. That's what we should all aspire to do with our research. So that's really fantastic. We will get to some questions from the audience in a bit. Why don't we go through the cases? I know, Brad, you have to run out in a bit, correct? So why don't you share your case? If you could share your screen and unmute yourself as well.
Yeah, thank you for that. That was really incredible. It's so nice to see kind of, neurosurgeon-led, kind of heavily involved in some of this work. I just had a couple of questions. Did you see any difference in the meningiomas based on location? I know kind of people have talked about that, either posterior fossa lesions compared with supratentorial lesions. Was there any methylation differences?
So that's a really interesting question. As you said, Brad, there is a difference between whether you're midline or lateral on the mutational signature, especially the paper by Priscilla and then Murat Gunal, I think both confirmed this. On methylation, we don't see a distinct difference based on anatomical location. There is ongoing work that Farshad is doing that suggests perhaps if you integrate, however, the different platforms, there will tend to be some differences in anatomical location. But on the methylation, such distinct pattern is not something that we saw.
Yeah.
Now, whether there's particular very small, very unique subpopulations, and this is a question, for example, that we would want to ask as a consortium, is are the tuberculin meningiomas very distinct from olfactory groove meningiomas? In my personal experience, it's not something that I've objectively studied, but in my personal experience, when you resect a tuberculum meningioma, it almost never recurs. And so there has to be something unique about the midline anterior skull-based tuberculum meningiomas compared to olfactory and then midline posterior.
Yeah, that's so interesting. And we're lucky here to have one of your proteges, Alireza, and
That's
hopefully
right.
get to, and hopefully get to get involved in some of the work you guys are doing.
Yeah, he's amazing. He has a lot of energy, so he will
yeah.
definitely get this done there.
Yeah, we're trying to exploit that energy.
Mm-hmm.
So, yeah, this is a very basic case. Just getting to kind of a common question. Certainly not with some of this more advanced methylation profiling, but with the kind of methylation switch and losing that MGMT methylation and how everybody addresses that. Just curious, kind of the approach of the group. But this is a young gentleman diagnosed before my time here with a large left frontal lesion, underwent initial aggressive subtotal resection. It was an IDH mutated methylated tumor, underwent concurrent temozolomide and radiation. This was his initial Caris molecular profiling in 2013, and then was under observation for a long period of time, and then had unequivocal progression in 2019 with kind of a new enhancing focus of disease, underwent an awake subtotal resection, mainly for biopsy of this lesion. And things were a little different. It was still IDH mutated, ATRX mutated, but now unmethylated. Unfortunately, no additional targetable mutations, with just an intermediate mutational burden, and the MSI was stable. This was kind of his newer results, which again, as we see with many of this advanced molecular profiling in these glioblastoma, that there's often really not anything to target. We're kind of hoping for those one-offs where there's maybe something unique about that patient's tumor. But how does the group address these unmethylated tumors when they were previously methylated? Do you still challenge with temozolomide, and what's your approach? And do you think kind of this more advanced methylation analysis maybe has some role in these?
Right, sorry, the writing is a bit small. Is that BRAF mutation says
not detected?
I see, okay.
Yeah.
Very young, right? I mean, it's, they fall in this adolescent and young adult population, which more and more we're now realizing they need a different treatment algorithm compared to their older counterparts. And though on histology, it looks like an IDH mutant glioma, probably their behavior is going to be very different. And you're seeing that, aren't you? You or somebody else, you said resected in 2013, and it's still, still
clearly,
now, correct? Like 7 years later.
Yeah.
Mm-hmm.
Yeah, exactly. Yeah, I mean, certainly kind of a different animal. And if I recall, there were some, I think, PNET features, glioblastoma with PNET features, and that's where the molecular testing comes into play, but had all the molecular hallmarks of an IDH mutant glioblastoma. And then you lose that methylation status and kind of left with not a lot of great options in the recurrent setting, in a lesion that's kind of in an area difficult to resect. He already has some baseline language dysfunction. And so this was now a couple of years ago. He did get re-irradiated, since it had been about 5 or 6 years since his prior radiation. So he had more focal radiation field there. And then he's gone on to did get Temodar, and it's obviously progressed through that, and has been treated with a number of other systemic agents, and it continues to do okay. But not great. But I always found these challenging, and kind of always curious if some of these newer techniques are going to reveal other unique features about this that we'll be able to exploit.
Yeah, I mean, I would say, again, at our place now, not in 2013, but now, 24-year-old with a IDH wild type or mutant glioma would raise our flag to say, let's do methylation to confirm that, in fact, the diagnosis is as we think it to be, because this falls in the category where, based on clinical features, we may question, or not question, but just wonder what the pathology is.
Yeah.
And then, as I said, there is really an emergence of looking at these tumors very distinctly as and not treating them as their adult counterpart. I don't see, or maybe I just can't read the screen, it's too small, the CDKN2A status, for example. And I don't want to speak out of turn, but I think our medical neuro-oncologists, medical oncologists or neuro-oncologists are really looking at this population very differently, and they would probably come up with a newer, upgraded list of chemotherapeutics to offer them upfront, as opposed to what we would have done traditionally so far.
Yeah. Yeah. No. Absolutely.
Roberta, you want to comment a bit on what your thoughts are? Yeah, I think you're on. There you go.
I think whenever we see a patient under the age of 30 with tumor with this pathology, we often do next generation sequencing up front to ensure that we're not missing an IDH mutation. And these tumors can have some variable natural history. So we see ones where, even in young patients, where they're actually rapidly progressing, even with very minimal or no residual disease, and ones that are quite indolent, like the one you presented, Brad. So,
yeah.
Whether there's additional mutations, like Dr. Sade mentioned, like the CDK mutants, TERT promoter mutations, that sort of thing that we can identify to try to classify them into more aggressive versus less aggressive subtypes. It would be interesting, Gallery, have you looked at the methylation profiling within the IDH mutants? Are there any differences within a particular subgroup of IDH mutants?
Yeah, it's a good question, Roberto, and great to see you, by the way. We have some data, in particular, looking at our IDH mutant and wild type lower grade tumors on methylation and also on metabolomics. It appears that there are two different subtypes based on a combination of the methylation and metabolic signature. And there is a group that behaves more aggressively, similar to a wild type compared to a mutant. And so they do divide. And as you know, the GSIMP profile of these tumors also bears on outcome as well.
Yeah.
Gallery, Mike Ivan here. Thank you again so much for talking. It was a phenomenal talk. In a case like this,
Thank you for inviting me.
Of course. In a case like this where it's challenging and the next chemotherapy option is a little bit, there's probably multiple options. Have you done the circulating DNA methylation kind of before and maybe after the next chemotherapy to see if you're seeing an early response in the tumor, or seeing if the methylation is changing at all from a new treatment to indicate any kind of success or progress with that treatment, or not?
Yeah, super good question. So actually, one of the neurosurgery residents who is in the lab now looking specifically at this sort of question has some very preliminary data, but nevertheless, I find it exciting, but we have to validate it. Primary to matched glioma, the signature of the circulating tumor DNA appears to be different. And so that gives us the information to say, it appears that at recurrence, and if we follow patients longitudinally, we will be able to detect a difference in signature in the circulating tumor DNA. And as you know, again, the field is moving in the direction to look at the tumor at recurrence and say, well, is the mutational profile very different now? Because after, especially chemo and radiation, the mutational burden, the copy number losses may have become more complex. But certainly at the very preliminary stages, looking at the question you just asked, it appears that there is a difference. And so we're going to pursue that further by increasing the numbers and adding a validation cohort. And more importantly, doing this longitudinally to follow a patient with a low-grade glioma and do longitudinal sampling to be able to detect whether there is a change in circulating tumor DNA, whether it's the differentially methylated regions that change, or whether even just the simple content of it may signal to us that the tumor is becoming active. And then similarly, from low grade to higher grade, of course, that's a separate question a little bit. However, an important one, again, to look at longitudinally and see whether earlier than MR imaging, we can detect a change on the circulating DNA.
Yeah,
Did I answer your question?
Yeah, that was great. Thanks so much.
Yeah, and just to follow up along very similar lines, if you looked at this in the differentiating kind of pseudo progression or radiative treatment effect from true progression, again by checking the circulating methyloma profile.
Yeah, absolutely, Brad. And we put this in a grant. I think Ali Reza's on that grant. So if we get it, we'll answer that question. I think that the challenge always is with these longitudinal studies, at least when I started out, I thought, well, you know, by the time I follow patients and do longitudinal studies, it's too late. But in hindsight, you know, one thing I would say that I would do differently is there are longitudinal studies that I should have started, because 10 years goes by and you could have had a wealth of data that I was too impatient to start collecting. But we are certainly collecting the longitudinal, and then being able to distinguish pseudoprogression. And then the more challenging one is brain metastases and necrosis, whether it's necrosis, whether it's tumor recurrence. It's always, as you know, a mixed bag. So I'm not sure that on the circulating tumor DNA you could distinguish that, but certainly something to look at.
All right, great. Khalil, do you want to share your screen?
Yeah, thank you, Dr. Zada. That was a wonderful talk. I had a quick question about some of your findings. Did you notice that there was any correlation between some of your methylation signatures and transcriptional phenotypes in your GBMs at all?
Methylation and the transcriptome in our GBM, we haven't really looked at it specifically. I think the multi-platform analysis of GBMs that TCGA has done is more extensive than the results that we would have. It's part of our analysis of what I was mentioning to Roberto for the metabolomic data, to see whether there's a expression analysis or expression pattern differential associated with it. But we haven't looked at that specific question that you're asking.
Thank you. You guys can see my screen all right?
Yeah.
Okay, great.
Yeah, if you could just go to, yeah, perfect.
Okay. I wanted to show a brief case. I mean, this is just an MGMT methylated tumor. This was a patient in her mid-50s who presented with a mild left upper extremity hemiparesis, severe left facial palsy, as well as persistent facial seizures. And you know, her preoperative diffusion tensor imaging, which we get on most patients, showed, as expected for a lesion in the lateral descending primary motor region, that it was close in proximity to her descending corticospinal tracts. I opted to do this surgery awake. Certainly it could have been done asleep with motor mapping, but she was a very cooperative patient, and I thought she would do well from being able to differentiate some of her fine motor movements in the OR from positive mapping results in her digits, which were important to her because she was a frequent knitter. You can see here during the motor mapping, she had a Berlandic vein descending anteriorly and superiorly, and then a positive mapping site below. I tend to use 5-ALA on all of my high-grade cases. And as we get towards the medial margin of the resection cavity, she's got some residual tumor tissue here, and she stimulates positive in terms of her electrophysiology, but she was still able to have excellent fine motor movements throughout the stimulation. So the resection cavity was taken a little bit more medially here. Post-operatively, she had a good resection. There was no residual. She went home post-op day 1, but she represented on day 3 after having a seizure while at home and had some frank left upper extremity hemiparesis, mostly in her hand, as well as a recurrent facial palsy. We also do post-operative DTI for some of our protocols, and you can see the descending cortical spinal tracts here. Although they're in very close proximity, they were mostly unmolested. And she ended up getting some steroids and doing quite well and was neurologically intact down the road. She had a relatively unremarkable course, and she's been free of recurrence for her duration, which is about 9 months so far. The reason I wanted to show this case was in terms of Dr. Zada's idea of changing the paradigm of how we treat patients with GBM and some of the things that we're doing both in the window between surgery and treatment, but also in terms of profiling some of these tumors to try and implement some change in the way we evaluate them. All of our tumors right now are currently being biobanked with organoids, and that those are explanted pieces of tumor that go into a suspension immediately after surgery. And then we are analyzing their RNA and transcription profile, DNA and transcription profiles, and also doing metabolic and lipidomic analysis and doing xenotransplants, and then banking those tumors for analysis in the future, which allow us to reanimate them and also test them. But these organoids can be cultured in vitro for an indefinite period of time for higher grade tumors and can be split after they grow. And then we're also able to culture some of the lower grade tumors as well. And in some cases, we're doing targeted analysis up front to determine quantification levels of certain either metabolites or biomarkers that allow us to differentiate for treatment effect. So this is an example of one of those organoids. This is actually the same organoid as from the patient that I presented. This is at 4 weeks post-operatively. And you can see that these organoids maintain cytoarchitectural characteristics, but also they maintain markers of stemness and vascularity and mitotic indices too. And then as we're using them, this is also a methylated tumor that we're evaluating with an agent that affects DNA damage repair. You can see the organoids manage to allow us to get some data on whether or not they'll be responsive. In IDH mutated grade 3 and grade 4 tumors, we've been looking at the quantification levels of R2-HG and their response to certain drugs within the same models. And my point through all of this, I think, is to try and get a sense of where along that pathway for institutions that are not incorporating DNA methylation, how we can really begin to try and incorporate that either preclinically in some of our models or in our clinical standard of care to try and really complete the loop for all the different things that we are still trying to catch up on, which is genomic analysis and transcriptional analysis and everything else, and how best to integrate that if we don't have that currently incorporated.
It would be really, that's an impressive resource, Khalil. The fact that you have the commitment, I imagine, a bit from the institution to do this. In terms of resource, it's a resource intensive work to do the organoids and all the analysis. So congratulations, that's very nice. I think adding methylation to the organoids would be a tremendous opportunity to then ask some of the questions you just mentioned and look at the methylation and correlate it to what the expression profile is and the mutation profile. And more importantly, to see whether your methylation signature, in theory it should, because it reflects your cell of origin of the organoid, is preserved compared to the tumor. And so that we would be really interested if you're open to this to look at it with you. And then more importantly, once you put them in the mouse, it would be interesting to see what is the methylation signature. Again, Matt Wazin, who I just mentioned, one of the residents in the lab, part of his project, which is really principally focused on primary recurrent matched gliomas and GBMs. We wanted to see whether the methylation signature of mouse GBM, whether it's xenograft cells or transgenic models that we have in the lab, are very similar and can recapitulate human. And it looks like there isn't a significant overlap. So if you can demonstrate that the organoid preserves the methylation signature when in a dish, and then when implanted into the tumor, into the mouse as a tumor, then I think just that characterization would be really valuable for the scientific community, because you can arguably use those tumors with more confidence that they recapitulate human glioma or a GBM. Is that the question you had asked me?
Yeah,
or I just got excited about the opportunity to do this and answered my own question. So yeah, those are my thoughts.
No, that's great. Thank you. And I guess from a clinical standpoint, at Toronto, we currently get just a binary result for our methylation. Are they MGMT methylated or not?
Oh, I see. Yes.
That's a second question. But yeah, I guess what is your pattern of care there, your clinical practice in terms of on a routine basis for your GBMs? How are you quantifying or qualitating methylation?
So for a routine, the routine glioblastoma, the MGMT is currently analyzed using the PCR technique. But for those that we get methylation, we use the array method. So we use the 850K Illumina array. We run it in the lab. You just need 5 unstained cuts of a paraffin block. So if we were to do the organoids, for example. But then when you get the methylation of the tumor, you could also from that derive MGMT methylation status, IDH mutation status, 1p19q, etc. So it gives you the whole range in the one test, which is the argument I use to see if the hospital would fund the test. But I haven't been that successful in my argument. I still pay for the methylation in the lab. So, but with respect to the MGMT, if we're not going to do methylation array analysis, we really just rely on PCR currently.
Just a quick question along the similar lines. Can you speak a little bit to the cost of this? I know, most of this is going to be having the funding from the lab and research initiatives, but
Sure.
We've looked at this at NYU too, and when we found that it was relatively costly, and I think we talked about it here at the University of Miami and discussing with the patient about the possibility of them paying, but I do think it becomes a limiting factor to some degree.
Yeah, a super good point, Carolina. The cost recovery of it would be $500 American if it's done in our lab. But the moment you put it in a pathology lab, because it has to be CLIA approved and the technicians have to be clinical grade technicians, the bioinformatics, etc., it suddenly goes up to $2,000. So we've come to an understanding that there is an addendum written in the pathology report that this is not a CLIA approved test. However, it's a test that we use in our clinical assessments. And so the test is done in my lab with our own team members. Some of them I mentioned to you during my talk. And then the results are integrated back into our tumor board, and our pathologist adds it as an addendum to avoid having to go from the 500 mark to the 2,000 mark. But certainly I think you mentioned NYU, Dr. Snurl is there as the neuropathologist, and we're talking about how best to make a case to then go to insurers in the States and ministry, in our case in Canada, to say it really makes more sense to do the one test that replaces all the other molecular testing. But as these things go, it somehow seems to be, there seems to be a bit of a resistance, and probably it's a matter of how broadly it would get adopted. And so then it would happen by default. I think one of the challenges right now is that the centers that do methylation array analysis are limited in North America and Europe. So maybe as more people adopt this, we would then be able to demonstrate its value.
Right. And what about the timing? How long does it take?
Yeah, so, if we were to get funding and do all of them, we would be able to go faster, because right now we keep the cases until we have one run. Right. But turnaround from, say, tomorrow you email me and say, Gallery, I have a case, and you put it in the FedEx and it shows up at our door, to the time we can give you a diagnosis is roughly about 2 weeks to 2.5 weeks. With COVID, we're a bit delayed, but generally it's that time frame.
Yeah, sometimes the methylation takes quite a bit longer than that in some institutions, so that might be an additional.
Yeah, and a consideration if you really need to make a clinical decision. But, for the Nomogram, for example, for meningiomas, there's no urgency to the decision on whether to give radiation or not. And we are really relying on that information quite heavily in the tumor board discussions that we have for grade 2s, grade 3s, and the grade 1s where the surgeon raises a flag and says there were some features about the tumor that just didn't seem like a grade 1. We've all had that, right? So you come out of a complicated, very invasive meningioma, and they say it's grade 1, and you say, I don't believe it, repeat it.
Yeah. Did you find any difference in radiation-induced meningiomas? And was there any cohort of that, or is that just too small of a number?
Yeah, good question. We haven't looked at it specifically. One of the other guys in the lab, Justin Wang, is looking at that right now to see, is there a performance that's different on the nomogram for radiation-induced meningiomas compared to the average meningioma that we get? Because again, as you know from your own experience, likely the radiation-induced meningiomas tend to grow faster and recur faster. And so that's something that we're looking at. Whether we have enough numbers, I don't know, but I'll come knocking on doors to have any radiation-induced meningiomas for us to validate what we find in our own cohort. Because it's one of these things, any one institution doesn't have the sufficient numbers, right? Grade 3s are not that many.
Yeah. Fantastic. All right, Roberto, want to share your screen with us, please?
So this is a 52-year-old man, previously healthy, presented with headaches, urinary frequency, and short-term memory loss in April of 2018. He had a gross total resection of right frontal enhancing tumor. The pathology revealed a glioblastoma, IDH wild type, MGMT promoter methylated. He went on to have MHART protocol, and this is our local McGill protocol, where patient receives 60 grays and 20 fractions, so 4-week radiation period with concurrent temozolomide and metformin. And then they go on to have adjuvant temozolomide and metformin for 6 cycles, which ended in December of 2018. He had progressive enhancement at the resection margin on surveillance MRI, which we thought initially was treatment necrosis. He was treated with dexamethasone, but had no response to dexamethasone. Remained with a very good KPS. He underwent resection of the enhancing margin in October of 2019, and the path revealed no viable tumor cells, just radiation necrosis. In April of 2020, he had new foci of enhancement in the left frontal lobe, and he had a temozolomide re-challenge from April to July, but unfortunately had further progression of the enhancing lesions in the left frontal lobe. And he underwent resection of those lesions in August of this year, which showed recurrent glioblastoma, IDH wild type, and MGMT unmethylated now. He went on to receive 35 gray and 15 fractions to the left frontal lobe, which just ended in October, and that'll be followed by lomustine based on our tumor board discussion. So this is the tumor. So we had right initial resection. He had radiation, and this was the enhancing margin. And so as Brad and Gary mentioned that, one of the potential advantages of looking at circulating tumor DNA may be in using it to distinguish treatment necrosis versus recurrent tumor. And I think this would have been a good case for that. And they have avoided doing surgery, this is the second surgery for this gentleman. You do see the progression over time from April to October. And so we were worried that this was, in fact, a recurrent tumor. So he underwent resection of that, enhancing margin. As I mentioned, there was no evidence of recurrent tumor, and he had surveillance imaging after that. Then we started to see these small enhancing foci in multiple sites in the left frontal lobe. And you can see typically the radiation field would go to the midline here. So initially we were wondering whether this is just radiation necrosis on the other side, just very close to the midline. But then you start to see these enhancing foci further lateral to the midline. And this was rapidly progressing. You can see from July to August, it almost doubled in size. And so, we were quite worried about this being a recurrence. We went and removed that. This was the lesions in the cingulate gyrus were not removed, so I spared his dominant cingulate, just given the neuropsychological effects related to resection of that. And he's done very well postoperatively and going on to more radiation treatment. But the question, for these, when they recur as unmethylated now GBMs, distant recurrence, what are the options? And our tumor board felt that given radiation to this area that had not previously received radiation may benefit him in the long to prolong survival. But certainly the options are getting more limited for this patient to go forward.
Roberta, how old was the patient again?
He was 52 at diagnosis. He's 54 now.
Challenging case. I can't say that I have much to add or offer. I think, in fact, you've been as aggressive and as possible with him. Do you have CSF on him?
No, we don't have CSF done.
Mm-hmm. Just curious as to how, you have a very relatively distinct lesion.
Do you see, if you're looking at primary tumor versus recurrence, do you see methylation profile changes from primary to recurrent tumor?
Yeah, very, very good question. So there's a paper that's published on a couple of hundred, I think, if I'm not mistaken. Again, Matt Wazine in the lab is looking at this, our neurosurgery resident. They do not see a difference in methylation. But when we looked at our own cohort of primary to matched recurrent gliomas, and our cohort is perhaps more enriched for IDH mutation and those that went from lower to higher grade, there is a subpopulation, so a distinct cohort of the recurrent, that their methylation signatures appears very different. Again, preliminary results, and because it's different from the prior published data, we want to be cautious that what we're seeing is real, but it looks that the methylation signature is different. So more to come on that. And the reason we're doing that, not to repeat the prior study, but really to now look at methylation and layer proteomics to see whether that can add an additional layer of information to refine what we understand of methylation, and also perhaps be able to give us a predictor of how gliomas behave. The challenge is that our population with gliomas outcome is so poor that this distinction between good and poor outcome, you need a considerable number of them. But there is a pattern that we're seeing on recurrence in our cohort, which previous publication didn't show this. So we're pursuing it further to see whether it's a real signature, and if so, is it possible that the prior study did 450K methylation array genes? Maybe the 850, the addition of another 400 or so genes, whether it falls in that category, and that's where you see the differences, perhaps in those CPG sites or other methylated regions.
Yeah, this was a very interesting case for us because we thought that the recurrence was going to be in the corpus callosum, but you see these distant sites. So we were initially quite baffled by these little foci quite distant away from the corpus callosum.
And it doesn't look from your scans, at least, but I don't know if they're contrasted, any of them in here, that he has leptomeningeal spread or transependymal spread, right?
Yeah, he doesn't have leptomeningeal spread. Yeah. So I just want to show this slide that our group here in 2016, we published this analysis of methylated versus unmethylated GBM receiving this 60 and 20 radiation treatment with neoadjuvant temozolomide. And they showed quite a good overall survival for the methylated, but not for the unmethylated tumors. So this, obviously, we've seen this previously, that methylated GBMs do much better. But I think, with the new type of radiation or even neoadjuvant treatments for radiosensitizers, knowing the methylation status at the time of diagnosis is going to be quite important in terms of deciding what type of treatment patients would be best kind of classified into, and also what the prognosis may be. Based on this data, we're really able to have a discussion with patients that are methylated versus unmethylated, and what we predict their outcomes may be.
Dr. Zada, do you see any intratumoral differences in methylation from different sites within the same tumor?
Yeah, good question. We don't. And I think it goes back to, again, perhaps the cell of origin defining the methylation signature. It appears that there is a uniformity to the methylation signature of each tumor. Now, again, similar to the discussion with Roberto, whether you increase the numbers, you would then find a subset that will have variation. Or more importantly, I think maybe if you look across the grades from a grade 2 to 3 to 4, maybe there you would see some differences. I'm not sure, but it's definitely a good question, or an interesting question to see.
I guess a question from the audience that sort of touches on the subject about the CSF that you had mentioned. What are the thoughts about the circulating DNA in the CSF and its use almost as like a liquid biopsy equivalent?
Sure. As you know, for peds, obtaining CSF is routine. In adults, we don't do that. So we don't have CSF banked currently sufficient numbers to be able to answer this question. But I think Brad is off, and his colleague who has joined him from University of Toronto, Ali Reza Mansouri, is leading one of the Big 10 consortia, and they have CSF that's collected. We're looking at the CSF to see whether it could more reliably detect and more accurately detect, in particular, the IDH status. The question then becomes, would this actually change our practice? And would we get to a point where we're comfortable to actually do CSF sampling of adults? Because I think it's very different, obviously, for adults than the pediatric population. But I know on first pass, the CSF proteomics looks very promising. We're processing the circulating DNA to see if the methylation signature is preserved. But the numbers are small. So again, something, the room for collaborating. And if there are CSF samples stored in different banks, definitely something to look at.
Great. I think we will have time for one last question here. Is there any data to suggest differences in dosing for radiation depending on methylation status for postoperative?
Not that I know of. No, I mean, unless you go with the New England publication a few years ago, where if your methylation, your MGMT methylated or not, and you're over or under 60, the regimen will change, or the recommendation would be different. Otherwise, I don't know of any. I certainly don't have that data. I don't know of any published data other than this publication that I just mentioned, where the clinical trial was focused on above 60 or under 60 MGMT methylated or not, whether the regimen for radiation would be beneficial in one or the other category. I don't know if others on the panel have
in our experience, so this is not the standards 2 protocol for our hyperfractionated radiotherapy. So in patients with methylated GBM, we're actually stratifying into enrollment into this local prospective study where they receive either neoadjuvant temozolomide and the hyperfractionated radiotherapy, or now, which we've transitioned to the MHART protocol, which is metformin and hyperfractionated radiotherapy. But we do find that the methylated GBMs do have a significant benefit from this higher shorter dose duration radiotherapy. So the downside of this is that we do tend to see higher treatment necrosis rates in these patients. And part of that is related to any residual tumor and enhancing tumors. So we're definitely selecting patients that are have a maximum resection and where we feel that if there are radiation treatment necrosis effects, that it would not cause them any harm in terms of quality of life or neurological deficit. So trying to stay away from areas close to the brainstem and so forth.
Great. I mean, I think in terms, when we're talking about meningioma and postoperative radiation, I think there's two thoughts. Some people do prefer larger field radiation as opposed to SRS to certain nodules or the whole tumor bed. So I think there's different thoughts, but I also agree with Gallery that I really haven't heard much about the changing in the dose of the that you're going to give in terms of SRS. Having said that, the ones that you are giving the radiation to, you already know they're going to be the ones that are going to be, more likely to recur. So as opposed to just any meningioma that you are treating grade 1 meningioma that's growing that you're treating without surgery, you're going to treat this at a little bit of a higher dose in terms of SRS, but that's a little bit of a different beast.
Can I ask a question, Gallery? At your center, what are you doing with the grade 2 meningiomas with Simpson 1 resections?
So Roberto, right now, I think the best answer I could give you, we go based on a case by case. And if the methylation really shows that the 5-year recurrence risk is very low, we have a discussion about whether or not we would reserve radiation. If it is a true Simpson grade 1, then we tend to observe them. And at the first sign of a recurrence, depending on its location, we may go back in for a resection or then go on to radiation. But as you know, it's very controversial. One of the ongoing studies, again, to continue from Farshad's work, Justin is looking at, is to get the samples from the 2 clinical trials. One is the NRG, the old RTOG clinical trial, to where patients were radiated versus observed, and see whether the nomogram can predict their outcome. And then the second one is the European sister trial, where they randomized grade 2s for radiation versus observation. Once that matures, hopefully we have the samples from that study, and then we can look to see whether the nomogram accurately predicts outcome in response to radiation. And if not, could there be a new signature that would then determine outcome to radiation? But I think it still remains quite controversial. We integrate it into our decision making and then reach on a case-by-case basis on a decision as to what to do.
Fantastic. Thank you so much. All right, guys, it's 6:33 now, so we're going to wrap it up. Gallery, thank you again so much to all the panelists.
Oh, my
guys. You're a fantastic role model to myself personally and to all of us physician scientists, so we really appreciate you taking the time to talk to us today. And congratulations.
Thank you, Carolina, and thank you again for the invitation. Have a good night.
Good night, everybody. See you next time.